We're going to move on to our keynote presentations. It is really my pleasure and honor to welcome our first keynote speaker, Dr. Nancy Young. Dr. Young is the Executive Director of Children and Family Futures, a California-based research and policy institute whose mission is to improve safety, permanency, well-being, and recovery outcomes for children, parents, and families affected by trauma, substance use, and mental disorders. Since 2002, she served as the director of the federally funded National Center on Substance Abuse and Child Welfare, has been the director of the Administration on Children and Families Technical Assistance Program for the Regional Partnership Grants since 2007. In 2010, she began serving as the director of the Office of Juvenile Justice and Delinquency Prevention's Technical Assistance Program for Family Drug Courts and the statewide System Reform Program in 2014. She led the effort to create the foundation-funded Prevention and Family Recovery Program to implement evidence-based parenting and children's intervention in family drug courts in 2013. Her work, her CV, I could go on. What I found to be quite compelling was also a personal component of her biography. Dr. Young and her husband, Mr. Sidney Gardner, fostered and subsequently adopted 2 children who embody the policy and practice issues about which the work of Children and Family Futures is grounded. So thank you so much, Dr. Young, for joining us today.
Thank you very much for the invitation to be with you all today. All right, great, thank you. When I got the email and I said, Colorado, oh gosh, I don't need to go to Colorado. They got it all together in Colorado. We have Colorado, go and talk to other people. So what in the world do I have to say to Colorado? So did a little bit more conversation and staff who had conversations, and we decided that perhaps there's some work still to be done in Colorado, and I hope to be able to help with that. The other part, besides being the adopted parent of now almost 31 and 32-year-old children who came to us through the child welfare system, is I am also a person in long-term recovery for 39 years. And so while we try and bridge the gulf between these systems, part of that is my own personal recovery. We adopted and we fostered and adopted children way into after I had kind of selected this was what I was going to do in my dissertation, and had finished school before the kids came to us. But the experience of parenting 2 children with fetal alcohol spectrum disorder that was not recognized, that we had enormous trouble getting help with early on. And now at 31 and 32, we actually moved from Orange County, California to Las Vegas because of the housing costs, because they won't be able to be in the housing market in some place like Orange County. So those long-term consequences are real. And I start that part of the story because I may have biases that you may hear about this mix between children's services, healthcare systems, and treatment systems. So I want to be clear, that's where I'm coming from. The work from this presentation is supported by the National Center on Substance Abuse and Child Welfare, although they're not supporting this exact presentation. But I wanted to give acknowledgement that much of the knowledge that we've gained is with that support from the federal government. When we think about how kids experience parents with substance use disorders, today we're really focused on the prenatal time period, but I didn't want to let go of, but these kids go home, and some kids that are not recognized as having prenatal substance exposure are living in environments which put them sometimes at risk, or sometimes just to maladaptive behavior about what's going on in their family. So if we put the blinders on only that we're about prenatal exposure and neglect the part about, and they go someplace, and then they end up adolescents. And far too often for children who are experiencing those kinds of situations in their family, they end up with experimentation and substance use disorder. So we want to make sure that we have this spectrum of the way that kids are affected, and policy responses can be in each of these three different buckets. But kids don't fit nicely into those three different buckets. As they mature and age, we want to be aware of that. Just several months ago, I think August or so is when it actually was released, we worked with the Vermont-Oxford Network. Does that sound familiar to any of you? Okay, good. It has nothing to do with Vermont or Oxford. That was the first thing that I learned. But they provide training and assistance to hospitals in improving birth outcomes. So if you scan that code, I'm old, I'm getting used to this, scan the code. I even did it a few times in the previous presentations. It will take you to a 4-part series on plans of safe care, which are specifically tailored to labor and delivery hospitals. Hospitals that are delivering babies, OBs, pediatricians, NICUs. What is your role in a plan of safe care? So I wanted to make sure that I didn't lose that and come back to resources at the end, that we're quite proud of that. And I hope that that will be helpful to you. When we think about those three different buckets of kids, is there something I can do to move it's not moving on my screen like it's moving on your screen. I guess I just need to also move that.
Yes.
Okay. I thought I was controlling that, so.
Yes, indeed.
That's right. I can figure it out. I can just page.
I'm going to restart you.
You're going to restart me?
Yes, I have to restart you.
I don't want to take time to be restarted.
Okay, just a second.
There we go. That's a quick restart.
What slide were you
Oh, one more. Okay, perfect. All right. Thank you so much. When we think about the data in these three different buckets, the largest percentage of children going into out-of-home care are infants. About 20% of all placements of children into the child welfare system are infants. We need to be aware of that. The childhood exposure and the ACEs and what's happening for kids and their own substance use issues. But if they are a child of a parent with a substance use disorder who is placed in child protective services, they are lengthier stays in out-of-home care, and they are less likely to reunify. And then again, the risks that continue into adolescence as they start their own substance use. These data are old. Look at the year. A decade ago, I just was talking to Dr. Wells about that this morning. But I thought important for us to think about both the short-term and the long-term knowledge base about prenatal substance exposure and what happens to kids. So in the short term, you see the opioids have a strong effect. Alcohol has a strong effect in two areas. But a lot of it is effects, but not ones that are statistically significantly strong effects. When you look at, but what gets into the media, what gets into our attention is this part about the opioid withdrawal, right? That's where we have a lot of attention put. And since the time of this study, we have much more data on methamphetamine. But when we look at the long-term consequences for children, the long-term outcomes, what sticks out? Anybody? The legal drug alcohol. How many of you experience persons who are coming in to deliver babies and they only use one substance? I didn't think so. Do any of you ask about the alcohol use at the same time that you're testing or trying to figure out about illegal drug use? This is profound. This is profound. I'm delighted to hear about Illuminate's and the other active experts in Colorado related to fetal alcohol spectrum disorder, but it can't be emphasized enough that we forget that the only substance that has this long-term strong effect on growth, behavior, cognition, language, and academic achievement is alcohol. More recent data, when we look at the educational outcomes, because you saw that there wasn't a lot on opioids, lack of data, some effect on behavior, the studies are kind of all over the place. But some more recent things that have been done on the educational outcomes for kids who actually had an NAS diagnosis was profound differences in the testing scores in elementary school all the way up into junior high if the child had an NAS diagnosis. Now, there's a lot of debate. Was that NAS or was that alcohol? I have my opinion, but I'm not a research scientist or a medical professional. I'm a social worker. So I don't know. But I have a feeling that that stuff that we didn't ask about, having my personal experience of parenting two children, that this looks very much like unrecognized fetal alcohol spectrum disorder. So what about the data on the child welfare system? And you may say, oh, why do I have to, I'm just trying to get babies born healthy and get them out the door. I want to focus on that. Well, in part because if you're handing off to the child welfare system, it has a pretty big impact on what's going on related to parents with substance use disorders. This is the national data. There's an item in the data set for the child welfare agencies that says, is that a child was removed and parent alcohol or parent drug use, or it actually says abuse, is a condition associated with that child's removal. So you see that if the child was under the age of 1, nationally over half of babies who are removed have that box checked. And if they're over 1, about 36%. Now, whenever I travel, not just starting to travel again, but whenever I used to travel, and I would ask people in the audience, does this resonate with what you find in the child welfare system? Absolutely not. They think it's much, much higher, much, much higher. The difference is that we don't have a really good job. We don't do a really good job of collecting that data. In Colorado, you do a lot better job. I don't personally think that you're that much higher in your substance use in Colorado than, say, Maine or Texas or somewhere else. But you do a much better job of noting this in the data system that says of the infants who are removed in Colorado, 3/4 of them had a parent with a substance use problem. Now, it's not a huge number of babies in Colorado. In 10%, about roughly 10% substance exposure. So 1 out of 10 of your births, substance exposure in your hospitals. With the number of births in Colorado, almost 23,000 in 2021. I'm using those data because that's the most recent data we have the child welfare data for. So you have about 2,300 births in Colorado with prenatal substance exposure. 3,500 total kids entered out-of-home care in 2021. 20% were under the age of 1. But this is remarkable. I have never seen this before, ever. None of the under 1s had missing data on that parent substance use indicator. So give yourself a round of applause, because typically that is mostly missing data, that we don't have people completing that data item. So I think that's a lot of training that's gone on in child welfare, a lot of standardized screening to make sure. But troubling, of the 697 were under age 1, it's about 30%. If you say 2,300 births were exposed, should have been recognized in Colorado. Now, let me be really clear. I am not advocating that all those 2,300 babies should be in out-of-home care. But somebody needs to know where they are. And maybe you do. Maybe that's already known in Colorado that they went to in-home services. But what's the gap between the 2,300 and the 697, and where are those babies? Because if there are about 1,600 in 1 year By the time you get to the end of high school and you accumulate that for 12 years, it's a large number of kids that we may be missing. And again, not missing to remove them, place them in out-of-home care, identify so that they can get the support that they need in early intervention, in preschool, in elementary school, to allow them to be successful as adults. So we don't want to neglect the maternal mortality data. You've seen a lot of this already today. About 1/5 of maternal deaths during pregnancy or in the first year postpartum due to substance use, suicide, or homicide. That is already been discussed about the increase that we've seen in this last decade, 2010 to 2019. But again, the disproportionality of who's experiencing those deaths, higher rates among American Indians and Alaska Natives on substance use related deaths in the postpartum period, suicide higher rates again in that same population, and homicide higher rates in non-Hispanic Black families, women who have given birth. The disproportionality is pretty stark. And so when I saw, it was terrific, the presentation that was just done on stigma and some of the data, when we say, oh, it's not in our hospital, race doesn't matter. Well, maybe it does if that is what is happening with women after the discharge. So about 70% of maternal deaths happen in the postpartum period, 20% in the 6 weeks postpartum, and about half of them 6 weeks to 1 year after. And again, you've seen some of these data already. I don't mean to be repeating, but what can we do about it? The continuum of where interventions can come into play is broad. From the discussion that we just heard from the moms in recovery about what happened when their first interaction with OBs. How many of you have OBs in your partnership in your local communities that are implementing screening during pregnancy? Do you know if they are? Some are, 2 are, some are, yay, yay. ACOG says universal screening using a verbal tool. Well, what happened to that guideline? Brief intervention, all of these things are things that I'm talking to Colorado. So you know all of these, and you have many of these efforts put in place in places around your state. Engagement during that prenatal period, because if the mom gets to the hospital to give birth and this hasn't been recognized, you were all way late. Because it creates for that family this trauma of giving birth, calling CPS, calling Health or Human Services here. And what does that mean in terms of what that inflicts really on the child welfare system? You could have known all along this baby was coming. You could have had a plan way in advance. Where's this baby going? If we wait until the time that they get to the hospital, we've missed the opportunity for prevention, and we've missed the opportunity to reduce some of that trauma for families, trauma for the child welfare worker, trauma for the systems, and expenses that carry over into all of the agencies. So why is it so difficult to get folks into treatment? Dr. Volkroff, who's the director of the National Institute on Drug Abuse, says that there are 3 primary reasons why people don't go to treatment. The first one, reimbursement policies. They don't know how to pay for it, or they don't have access to insurance or other ways to be able to pay for that. The second, a lack of workforce. We're all struggling with that before COVID and after COVID about a workforce. And the third is stigma. Now, how many of you think that you could control reimbursement policies? How about the lack of the workforce? Okay, you got some things you could do about the workforce, right? Maybe it's really hard. How many of you think you have complete control over the stigma towards people in your hospitals? Well, you have your own control over your own language, your own stigma. You just heard from experts about what they experienced. You have major, major control over the way that people experience stigma around their substance use or mental health disorder. So when we think about stigma, it's important, I think, to break it down into what do we mean. It's not just all of the self-stigma. It's also about that structural stigma. Why is it so difficult to get people into substance use treatment? We've had policies for generations, as long as I've been around anyway, that have not funded substance use and mental health services at the same rate of other areas of health practice. Public stigma about the belief that people chose this, that it's not a brain disease, that it has, that they're affected by the substance use disorder of their own will, has nothing to do with ACEs. Okay, I can't resist. I have a real problem with the term behavioral health. I know it's ubiquitous. I know everybody uses it, and I'm like a lone wolf, I feel like sometimes out here. Why do we call this area of medical practice of a brain disease, of a substance use disorder, and a brain disease of mental health conditions, and why do we blame the person's behavior by calling it their behavioral health? I know it's out there. I think it's one of the most stigmatizing things we can say, but I'm on a not just a one person, but a campaign. Can we just acknowledge calling somebody that has a substance use disorder as having a mental health issue, a behavioral health problem? When what we're trying to say is we recognize that you have profound ACEs in your childhood. You have profound trauma, particularly for women that develops their own substance use disorder. So then self-stigma, I think that's what we talk about a lot. These are some quotes that came out from a publication, again, from NIDA, the National Institute on Drug Abuse. I overheard the nurses call my baby the NAS baby. We heard this already about the talking behind the doors. They never used her name. It's a stab in the heart. I felt so embarrassed. It was so demeaning. I found out that I was pregnant in the middle of a relapse and thought I could not keep the baby. I did not feel motivated to keep the baby. I also felt shame and mortified in trying to get prenatal or drug treatment help. I knew they would judge me. They would also judge me if I lost the pregnancy. There was no way out. The thought of walking into a hospital and saying I am using was terrifying. To tell somebody what you've been doing is scary and the hardest thing to do because you don't know what you're going to, how they're going to react. Lady, there is nothing you can say to me worse than what I have already said to myself. Are you going to judge me or help me get help? Those are, with the other quotes that we heard this morning, I think really important for us to put ourselves in those shoes, because that's what empathy is, right? Being able to walk in somebody else's shoes to understand their life experience. This you've already seen today, the change in language, but this was from asking medical providers, if you had a case that was described as a substance abuser, what were the feelings about that? If you had a case described as a person with a substance use disorder, what were the reactions to that? Fueled by misconceptions, the more you can get the women that we were just heard from, the Tough as a Mother campaign, the more you can get that into your hospital, into your practices, the better, to be able to make sure that people see not only the troubled person who's homeless on the street, but a person with 39 years of recovery who has a Ph.D. We're out there. Engage them. Engage people in new recovery to help with others. Inaccurate portrayals. You've heard all of this already. That last one, I was delighted to hear about the training that you have available for nurses about assessing their own biases and developing a response. Again, we've heard about the work at Boston and Dr. Grossman. The most important thing I think that he said that stuck with me so much, this more mom, fewer drugs. It's kind of a slogan, but I really liked that. But the other thing that he said, in their 10-year effort to change their hospital approach to parents with substance use disorders, was that, sorry for all of you who may have answered those surveys that you've been working in the field for like 20 plus years, or you've been at your hospital for 20 plus years, is that some of the nurses in labor and delivery, some of the nurses in the NICU had to move on. They couldn't change the culture to embrace the idea more mom, to embrace the idea that we were doing rooming in, that these moms had as much right to have contact with their babies as every other mom. So not that I'm trying to work anything about that workforce problem that you have, but check you in each of the hospitals and checking ourselves about who needs who can change the culture. You know about the Tough as a Mother campaign. I didn't want to just act like we were talking about stigma and have me not recognize that. You also heard some about this model state legislation that came out from the Legislative Analysis and Public Policy Association last spring. And it proposes for a state, here is written language about how to change your laws. Now, Colorado has some of the best laws, but Colorado also says that prenatal exposure is substantiated child abuse. Did you all know that? There are some conditions in which it's not, but it's still, I could be wrong. I could be out of date. But according to LAPA's analysis, it still had with these conditions that it requires a report that it requires that human services have a report. Do you have a notification system now? Okay, so with some caveats about who's not reported. So that's not to say that you can't work within those boundaries. I don't know. Jade's maybe hopeful for that national CAPTA policy. I don't know. I don't think it's going to happen this year because we don't even have a speaker. But other than that, maybe it's going to happen. But some of the things that you're already doing within your existing statute, but if it requires a report to child welfare, and you're not in that category, but prenatal exposure can be substantiated abuse or neglect. So all of those pieces need to be looked at when you're trying to say, what are you trying to do in a plan of safe care? Now, the model legislation changes plan of safe care because it's so aligned with CPS, right? A safety plan. People have a hard time knowing what's the difference between a safety plan and a plan of safe care. So the term family care plan is what is supported in this legislation, this model legislation for states. A family care plan is preferred term. It's less stigmatizing. It really is an effort, and hopefully in the prenatal period, for the family to work with the care providers. What do they need in order for not just the baby to be safe, but for the mother to be safe? If we look at those postpartum mortality, we cannot possibly say that our plan of safe care is not encompassing at least 2 generations. And that was pretty dramatic change that happened in 2016 that said that the plan of safe care had to address the needs of both the baby and it says in the statute, family/caregiver. So a plan of safe care automatically is 2 generation. What's the purpose of that model law? I'm not going to go through all of these, but I wanted you to know that that exists. I know all of you are not working at the policy level in your state, but it's important to understand what these national groups have put together about what is a model for a state's legislation. Again, during that first visit with a pregnant person, a written or verbal screen, ideally not done by the doctor. Ideally done by somebody who is doing outreach, somebody who is perhaps a person in recovery, somebody who is engaging with that individual. Follow-up screenings at any point, and either a referral of assessment to determine treatment or referred to another practitioner or entity to create the plan of safe care. This is the language that they give for states to be able to adopt, that an infant experiencing withdrawal or born affected by parental substance use disorder is in and of itself not a report, finding, or presumption of alleged child abuse or neglect. And that is different than, again, I don't live in Colorado. I could be out of touch with what your current state law says. But I think that currently it can be substantiated maltreatment without the other kinds of things that we would look for about risk to children. Housing, person who is caring for the child, stability in the enough stability to be able to have the child live safely in that family. So separating the substance use from the risk and the safety of the baby becomes pretty important. Yeah. Thanks, Jade. I appreciate that. Yeah, that's major work to get done to change that. I'm gonna go through this quickly to get to some of the examples of what happens at hospitals in some other jurisdictions. What's important is this part about the plan of care. If your parent gets to the hospital and doesn't have that in place, that postnatal plan of care shall be created prior to the baby's discharge. Are hospitals doing that in Colorado? Babies go home with a plan of safe care pretty much all the time. Not all the time. And again, I came here saying, why am I coming to Colorado? You guys have it together a whole lot better than most other states. So I'm not trying to pick holes in any of that. But why a family care plan before the child's birth? I first heard of this in Burlington, Vermont, and it was probably 13 years ago. And I was there for another kind of TA thing. And they had this group that was coming together every month. And they were identifying women with opioid use disorder at the high-risk pregnancy clinic. And they were putting plans in place before the baby was born about where the baby was going to go. And I thought, this is revolutionary. And they had child welfare at the table. They were able to use their state legislation that said that child welfare could open an assessment case in the 30 days before the baby's birth in order to have child welfare able to communicate with the other healthcare providers so that they weren't getting this information while the baby's 8 hours old at the NICU. They knew in advance. They weren't opening an investigation. They were saying this is an assessment track, but now we know before birth what's going on so that we can have a plan after birth that prevents removal, except for in cases when they really do have to have a safety plan. What it did was it reduced the cost for the hospital, for child welfare dramatically, because they already knew what was happening beforehand. That's, I think, something that isn't always happening in Colorado. And I would encourage you to look at that possibility of making sure that human services can have communication with you. Now, I know there's a lot of red flags. Do we want human services involved with pregnant women? This is where trust and values come in about how you could make that happen in good communication. Does bad practice happen in CPS? Yes. Does good practice happen in CPS? Yes. Does it take building trust in local offices with local hospitals and local physicians to say, this is what we're doing. This is mom, this is Sally, this is what's going on. She has Nana at home to be able to help her when she goes home. Or she doesn't have housing. She's not maintaining her treatment appointments. All of the things that we would be concerned about safety or risk for the child. You know all of that before the mom comes to the hospital. Why do we act like, oh, we have to wait until then to figure that out and make a plan? So I would encourage you again about this prenatal period and how to do that. The model legislation says all of these people need to be involved in the plan, in the family care plan. That all of these systems are part of the service array that certainly not every family needs every one of these services, but knowing that you have those services at the table for when that parent does need the service is very important. The other part that the CAPTA statute doesn't say is that only child welfare can create the plan of safe care. It does not say that. Child welfare is responsible for reporting to the federal government about the plans of safe care and the services that were provided for infants and their family. They have that responsibility. They're accountable for that. But it doesn't say that if you are an opioid treatment program, that you can't be held accountable for developing the family care plan way before birth. If you're a substance abuse treatment agency and you have a pregnant person in your agency receiving treatment, you are accountable, in my mind, not in the law, but you are accountable for making sure that there's a plan before the mom goes to delivery. If all of those other systems were taking their part of having a plan, who's interacting with this pregnant person before she gets to the hospital to be able to have that plan to better communicate and reduce the noise? Because there's a lot of noise that goes on at the birth event about making sure that we have CPS here. I know you guys call it human services. It's hard for me to switch. But making sure that the child welfare agency is notified, all of the things that need to happen. I'm going to skip through some of this because I want to get to the key considerations in planning for that hospital discharge. So again, if there isn't a family care plan before the person got to the hospital, then I believe that it's everybody in this room incumbent on you to back up and figure out who knew about this mom before labor and delivery. They probably suspected or knew or had perhaps even done a screen that knew that this mom was somebody who needed to have assessment and treatment services. How do you engage those folks to have that plan in place before the time of delivery? But that's key consideration at the time of, is there not a plan already? If there isn't a plan, what services are included? If there is a plan, a whole list of things that the folks have put together about what needs to be in the plan. I already know that you all have a template, you have a family care plan. All of that is already worked out, but I think who's responsible for it is one of those challenges that you might want to be looking at. Who's the lead agency tasked with ensuring that the families are engaged in services? Okay, I'm going to be bold here because I've known Dr. Wells for many, many, many years, and I heard her say warm handoff, warm handoff. If she's listening, closed loop referral, closed loop. How do you know that the person from that list of referrals got there, got the service, and had some feedback back to the referring agency that closed that loop, that something had happened? Because a whole list of referrals doesn't mean much in service delivery without it being a closed loop referral. Again, the chosen collaborative has guidelines for the safe discharge. Are all of you already aware of those? No hands are going up. Either that or like I have totally lost my audience. One. Second option is you've heard this before, and or three, you're just really ready to go to lunch. I would encourage you to look at some of the work that Dr. Wells and Jade put up this morning about the pathways and the collaborative to make sure that that is operating in your hospital. The other part that's after discharge from the hospital is what happens to the baby. So in those roughly 1,600 babies in which there was exposure, but they were not removed, how do we know where they are and that they're getting the interventions that they need? I'm very impressed with the data that you're able to show about getting referrals to early intervention. One of the very few places in the country that can show those data and have that in place. But for pediatricians, are there any pediatricians in the room? Yay. Do you ask about substance use history when you're engaging with a new family during infancy? Yay. So AAP says that this should be something that's asked for each of the new intakes into pediatric practice, incorporating it into the regular way in which you're asking about that infant. This is from Dr. Waite that says this is how he asks it. Dr. Waite and a few others put the AAP guidelines together about asking for substance use during pregnancy, in pediatric care. How far along were you in your pregnancy when you discovered you were pregnant? That's not, alarming. That's not going to say, did you use drugs quite yet? You're building that rapport. Did you have any medical problems during your pregnancy? Were you prescribed any medications during your pregnancy? Before you knew you were pregnant, how much alcohol did you drink? After you found out you were pregnant, how much alcohol did you drink? What about any other substances, cannabis, cocaine, or other drugs? A way for pediatricians to be asking, should I be concerned if I get reports when this child is 3 and the daycare center is getting ready to expel this child? Again, before when I used to travel, I would say, how many of you heard of preschool kicking children out of preschool, children being expelled, right? I don't know. You guys are more expert in some of this neurodevelopment than me, but to me, it seems like it is undetected neurodevelopmental challenges, sensory integration challenges. The child gets overwhelmed, acts out, and ends up not being a good fit for that provider. The next point in time when we see this happening is in 1st and 2nd grade, handwriting, math. Math is very, very difficult. 4th grade, they usually get a study team in 1st, 2nd grade study team. By 4th grade, they're getting an IEP. I love that you're shaking your head and saying yes. That's great. I'm happy that it resonates, because that's certainly the experience in many, many communities, that's when the kids show up into special education. So if we could back up and ask these questions at the first intake for every infant child going to a pediatric practice, and understand that when these neurodevelopmental kinds of symptoms arise, that we know what to be asking about and what should the interventions be. So I mentioned this notification. There are 11 states that do not have a requirement that there is a report to Child Protective Services when they identify an infant with prenatal exposure. Instead, because what CAPTA says is that child welfare needs to be notified. So they have figured out the difference between a notification. We did the plan of safe care. We're the OTP, opioid treatment program. We're the residential program where mom has been. We're the outpatient provider where mom has been. We're the public health clinic where mom has been getting her prenatal care. We're the high-risk pregnancy unit, perhaps at the hospital. We've done the plan of safe care. We're going to notify Child Protective Services that that's done, because we don't have concerns. This person is stable. We don't have immediate safety concerns about this child's well-being. A notification is what is required by the Child Abuse Prevention and Treatment Act. Recently in Washington, they too have implemented Eat, Sleep, Console. They adopted a computer portal system similar to Connecticut's computer portal that walks the healthcare provider through a decision tree about when do you need to make the report about safety concerns for the child, and when is this appropriate for the healthcare system, social services more broadly, other agencies, treatment agencies, to develop and oversee the plan of safe care. And we don't need child welfare involved. Our responsibility is to notify them that this plan of safe care exists. Have any of you been trying that? Is that something that's on the radar screen in Colorado? Is it part of the pilot? Sounded like it. So the pilot will be in a few communities to test out this notification system. That's terrific. So in Washington, the other part about, if you ever look at that LAPA report on the model state legislation, you'll see a thing that, not everyone was in agreement in all these points. It was oftentimes me, I have to say. But one of the things that I'm not a big fan of is a notification system that's anonymous and nobody knows. If that notification isn't being followed up by the pediatric practice or a community-based agency who's making sure that the needs are being met and the referrals are being kept and that services are being delivered, then it's sort of a family care plan in the sky that nobody really has any awareness of. And not to say that all parents with substance use problems are transient, but often they move around. And how does it go from one provider to another to make sure that that is happening in terms of care for the child? So when they need to make a report to child welfare, it's clear what those criteria are. When not, they're referring to a community agency called Help Me Grow, which provides that support and the connections to the community services. It's a case management kind of function. A lot of, I think, what you do in your home visiting program could fulfill that role, but it's not a notification. Nobody knows about this. There's a concrete service that's behind it to make sure that the infant, that the mother, that the family doesn't fall through those cracks. Help Me Grow, just a little bit of explanation when you see that. In Wyoming, a couple of years ago, we got a call that there was a state legislator, very well-meaning, who said, we need to criminalize prenatal substance use because there's just too much of it. And if we could just lock those women up, it would go away. That wasn't really what she said, but that was kind of the attitude. So this has been a major, major shift in Wyoming. That's where they started about 2 years ago. And what they got signed this year was legislation that is really grounded in some of those principles of the model state law, that there is a notification system, that the family care plan is developed with the parents, with the family, the guardians, and that there's a priority for keeping the infant with the family as long as the safety and well-being of the child can be maintained. So they did, I guess that is at a 360 to go from the same legislator who was saying, let's criminalize this, to supporting and getting passed through their legislature to change that approach to family care plans, which will go into effect in the beginning of January. Many of you have heard Arizona present before about the work that they've done. And I just wanted to emphasize, I know that is unreadable, but it's in the PowerPoint, which I think you'll get in follow-up, but to emphasize this part of the birth event. So at the birth event, the hospital makes Arizona EIP, so early intervention program referrals, directly right there when the baby has been identified with prenatal exposure. They're in the loop for early intervention. And I know that's some of what you have going on also. Is there a mandated report required? If yes, they go into the child welfare system, who's responsible for doing the family care plan. If no, they have a variety of agencies who are the plan holder that's developing and overseeing the family care plan. What that means is if that plan holder has the responsibility of making sure that those are closed loop referrals, that the parents have the services that they need. How many of you read the New York Times Magazine article that was so disturbing? Do you know what I'm talking about? It was a case in Arizona that went very wrong. Baby was removed. Nobody, well, then I didn't need to mention it. But that it was sort of the worst of what you could expect for the birth parent. And at the same time, the same week, there was a news article or a news story in New Mexico on the opposite side, of saying we're leaving too many babies at home. So this balance of how do you make this right decision about when should babies be protected, that criteria, and when do they stay home? Arizona does that because in both cases of yes, baby is in-home services, no, or in this case, the no is that they're in out-of-home placement. There is a team decision-making meeting immediately that brings the teams together. So it's not just the out-of-home care cases that are getting this kind of support, but in-home cases also. I think that's pretty cool to say that we're bringing the team together, both for in-home and out-of-home cases, to make sure that families have what they need. And I underlined that the pediatrician is aware of the prenatal substance exposure, because so often that's lost in the record. And again, look for preschool, first grade, second grade, a study team, fourth grade, an IEP. So we need to back up and make sure that that early intervention is in place. Delaware, again, you've heard some of you have probably heard a lot about Delaware and how they handle their plans of safe care. They actually contract for low-risk cases with a substance use treatment agency that develops and monitors the plan of safe care for cases in which the children are staying in home. They're not high-risk cases. So there are a variety of ways in which people are putting in place this post-discharge. Who has the accountability? How do we partner with our child welfare agency in a way that helps them and helps our families? And I wanted to end on this idea of the closed loop referral, because I think it's so important that the data that are collected to go in for plans of safe care are about, like, referrals were made. That's great, but what happened? Somebody needs to know what happened. Somebody needs to know, did that early intervention referral result in an assessment, intake to the program, infant, toddler is getting the kinds of services that they need? I know that this was a bit repetitive from some of the things that you heard earlier. I am delighted to be able to share with you today, and I'm also delighted that I'll be able to stay around. So if you have any questions or comments throughout the day, please engage in a conversation with me. I'd love to hear from you. Thank you so much.
Thank you so much, Dr. Young.